So while they're entering, I'll go over some details. I'd like to welcome everyone to the Vasculitis Foundation's webinar today. I'm Kathy Olewski, the host for the Vasculitis Foundation Educational Webinar Series. I'm also a patient living with MPA vasculitis. These webinars are part of the Vasculitis Foundation's commitment to patient education. And today's webinar is Glucocorticoids and Bone Health with Dr. Bobo Tanner. And after we finish this webinar today, there will be a recorded version on the Vasculitis Foundation's YouTube channel, and everyone who's registered will receive an email with a link to it as soon as it is available. And I'd like to introduce our speaker for today. Dr. S. Bobo Tanner is a graduate of Harvard University and received his MD from Wake Forest University. He completed his internship and residency fellowships and board certification in rheumatology and allergy and immunology at Vanderbilt University, and later served as a registrar in the Department of Rheumatology at the Royal Free Hospital in London, England. As founder and director of the Vanderbilt Osteoporosis Clinic, he sees patients with a variety of metabolic bone conditions. And thank you so much for being here, Dr. Tanner. We're so happy to have you to educate us today.
Well, thank you, and thanks for inviting me, and thanks everyone for participating. I'm going to go ahead and share my screen, and we'll get started. So I hope on your screen there's a big black notification that says steroids in your bones, what you should know. We're going to go through some slides that I hope you'll find educational. Our agenda is going to be the concept of an osteoporosis overview and talk about why we worry about osteoporosis and how steroids that are a mainstay of treatment in vasculitis, how they affect bone, and how bone density testing can give you better insight into how it's affected your bone and what are some of the options as well. I do research for a great deal of different entities, and the only commercial research support that I get is from a company called Amgen that makes products for osteoporosis, but we're not going to be talking about that specifically today as well. So what is osteoporosis? Osteoporosis means thin bones that break easily. They are typically, the broken bones are typically in the spine, the hip, and forearm, but they're not the only ones that happen. There are certainly others. One thing to remember about spine fractures is they're very often not symptomatic. About 2/3 of them happen fairly gradually and nobody remembers an acute event. It's only recognized because somebody happened to notice you'd lost 1.5 inches of height or more and happened to get an x-ray of your spine and see it as part of that. That's why a good height measurement's important at least once a year. We typically think of that being done in the pediatrician's office, but it's good for adults as well. Certainly, there are other reasons for height loss besides compression fractures, kyphoscoliosis, bad posture, thin disc, etc. But it's a clue to start looking. A lot of people use the term osteopenia. It actually has a numerical definition when you look at bone density, but it's less severe than osteoporosis. It means thin bones, but not everybody needs to be treated with osteopenia. It just depends on your risk factors. These are some photomicrographs of normal bone on your left and osteoporotic bone on your right. And even folks that don't look at these regularly can tell that there's a whole lot less bone on the right side, and some of the connections look pretty thin. This is what happens when bones get thin and no longer support the skeleton. They can actually break fairly easily. And we don't do biopsies very often to find out if you have osteoporosis. We use things like bone density measurements as part of it, but this is just what we're trying to avoid as part of treating it. One of the reasons we try to avoid fractures is because they have a pretty devastating toll on someone. We talk about the 4 Ds of a hip fracture. Certainly, it's a cause of death in some folks, about 20%. That's the same mortality rate as getting breast cancer. And I dare say most people don't recognize that as well. It's a big deal when you're older to have a hip fracture. It's a life-changing event. Some folks worry most about problem number 2, and that's disability. Once you've broken a hip, it's often that you don't get back to your full capacity. You're walking and going upstairs and conducting your activities of daily living may be somewhat limited, and this is a big concern for a lot of people. It's interesting that 20% of females have been noted to require assisted living after a hip fracture as well. You might be surprised to learn that the percentage for males is actually even higher. We don't tend to do well with things like hip fractures as well. And then the problem of getting your hip fixed in the middle of the night or weekend and surgery and so forth, things like delirium and dementia from all this staying up all night and anesthesia and things like that can set in, and it can be a real further change in your lifestyle. So those are certainly reasons we want to avoid hip fractures if possible. Who gets osteoporosis? Well, typically after age 50, your bones start to decline. The thickness of your bone tends to go away, particularly in women who no longer make their estrogens. So they go through menopause. Men too start to lose bone, but not the same rapid rate that women do after menopause. Add steroids on top of that, and it increases the risk of bone loss as well, regardless of your age or whether you're pre or postmenopausal as part of it. And yes, steroids can cause bone loss in men and children as well. So these are all concerns for folks who are treated for steroids or glucocorticoids, and that's why we pay attention to it. Steroids do a lot of things in your bones, and this is a chart to help you understand that. They can certainly cause your kidneys to lose calcium. They can cause your stomach not to absorb calcium as well. They decrease the amount of active vitamin D. They change the way your cartilage grows. They change the cells that help you build bone. They increase the cells that remove bone, and they cause some of the cells that are regulating bone to disappear as well. So steroids have multiple ways that they can affect your skeleton. On the other hand, they can be life-saving, and they're really important for a lot of treatments. They're the difference in whether you live or not and whether or not other organs survive. So we have this yin and yang and this balance that we have to draw with steroids about using them for their good purposes and being careful to monitor them for some of the potential side effects as part of it. The bone density machine that we use to examine your bones looks something like this on the left. It's about the size of an exam table. You'll see that the technologist sitting there beside them. The technologist doesn't have to wear a lead shield. It's a lot less radiation than a regular X-ray, and in fact, you probably get more radiation flying across the country on a commercial airliner than you do getting a bone density test as well. The upper atmosphere has radiation in it as part of it. And the pictures that it generates are here in the middle and on the right. The middle is what it will show when you look at the spine. We only do the lower part of your spine because if you go up on the spine, the ribs get in the way and the machine can't tell if it's measuring bone in the rib or the spine. But the point is to measure how much bone is there. And on the right is the top of your leg called the total hip. And up in the corner, you can see the ball and socket of the hip joint. And that little narrow place in the middle with the yellow rectangle over the top of it is called the femoral neck. And the neck is not the neck that holds your head on, but the neck in your hip. And that's what tends to break when people have hip fractures. So we're very interested in how much bone is there as part of the analysis. You can also get a forearm analysis as well as part of this. Medicare will pay for bone density testing, and in fact, they outlined the reason they would do it back in 1997 in something called the Bone Measurement Act. And a lot of commercial insurance companies follow suit and do accordingly. And these are reasons that we order bone density. We order it for other reasons as well, but this at least is an acknowledgement by Medicare that they will cover the cost of a bone density test, particularly in women who no longer make their estrogens and gone through menopause, or perhaps you've had a spine x-ray for other reasons and it shows that you've already had a fracture or some evidence of osteoporosis. And number three is maybe what catches most of the folks who have been treated for vasculitis, and that's the fact that they've been on steroids at least 5 milligrams a day for 3 months or more, or the plan is to leave them on steroids 5 milligrams a day for 3 months or more as part of it. That qualifies as treatment. In fact, it qualifies often as getting the bone density fairly frequently. There's a set of glands in your neck called parathyroid glands to be distinguished from thyroid. They're not the same. But the parathyroid glands sometimes get overly active and they can cause bone loss. And that's one of the other reasons that Medicare recognizes you can get a bone density test. And then if you want to follow up someone and see how they're doing, Medicare acknowledges that you can repeat the bone density about 23 months later, not even 2 years as part of it. However, if you've been on prednisone or steroids or glucocorticoids, they acknowledge that you might need to see them sooner and do the bone density even earlier. So they have codified all this in the Federal Registry way back in 1997. And so it's a good thing to know about in case your insurance company says no for some reason. These are really valid reasons. The machine prints out something called a T-score, and we should talk a little bit about that. It was named after a man in Waltham, Massachusetts called Tom Kelly, who was on the original committee with the World Health Organization to design bone density testing. And they thought he did such a good job, they were going to name the new scoring system after him as well. And a T-score really is to take the bone density of a woman after menopause or a man over age 50 and compare it to the time in life when bones are usually at their best at age 30, what we call peak bone mass. And that gives you some type of comparison to a time in your life when your bones were probably at their best. And that's how we judge how thin your bones are, is how much have they changed from what we consider peak bone mass in your 30s. Now, if you're young and less than 50 and certainly a male less than 50 or a teenager or a 20-year-old, we don't use T-scores. They don't have the same meaning in terms of your risk of a fracture as part of it. We use something called Z-scores, which compares you to people your own age. And Z-scores are graded on a completely different scale, and the knowledge about whether they lead to fractures is completely different. So it's important that you be very careful about blurring distinctions when you see a report and you see T's and Z's on there, what's low, what's high, and so forth. It really does take somebody who's familiar with the field to interpret it. And I'd be very cautious about leaping to conclusions without some guidance in this area. The actual numbers that we use, if you're over 50 and a male or a woman after menopause, maybe you went through menopause early, then these would apply to you, is if your bone density is not as bad as -1, then it's normal. If it's between -1 and -2.5, then it's considered osteopenia or low bone density. If it's worse than in other words, more negative, worse than -2.5, it's considered osteoporosis. And if you've already broken a bone, then you get to be called severe osteoporosis because you're now high risk for future fracture. So those are the criteria that were laid out way back in 1994 with the World Health Organization. They subsequently adapted the same cutoffs for men as part of it. And it was later an organization called the ISCD, International Society of Clinical Densitometry, that endorsed using Z-scores for young people, but the criteria are quite different. We don't use words like osteoporosis, osteopenia based on Z-scores. That would be an incorrect interpretation. Here's a map I often show to patients. The graph up in the left-hand corner is really a graph of the normal changes in bone density as a woman grows up in this country from age 10 to 90. Men are similar to this. They tend to achieve a higher peak bone mass than women, and the way downhill after the peak bone mass is a little more gradual than it is with women. But you can see from age 10 to 20, you accrue most of your bone density. That's when your bones get thicker and thicker. I'm not talking about how tall you are, but how dense your bones are, how much calcium's intercalated into the structure of your bone, such that by the time you're about 30 years old, you're at peak bone mass, and that's when your bones are thickest and strongest and least likely to break. But bone is a very active tissue. Every year, you remove and replace about 10% of the bones in your skeleton. You have the system of bone cells that go around surveying and take away old bone, and another set comes in and puts in new bone. So you're always remodeling, regenerating, renewing your skeleton at a rate of about 10% every year. When you're in your 20s and 30s and 40s, that process is pretty tightly coupled. You remove and replace the same amount. So you don't really gain or lose any bone during this time. You just get new bone, and new bone's a lot stronger than old bone. And so we are very happy that happens. The problems come in when you start to go through menopause, or as I mentioned, men get into their 50s, and you don't have this matched system anymore. You're still removing and replacing, but you tend to remove a little bit more than you replace, to the tune of about 1 or 2% a year. Men remove a little bit less than women do, but there's this downhill force that takes place. If you're on prednisone or cortisone, it tends to make that gap even bigger, typically 2 to 5% a year that you lose as part of it. And hence, we tend to pay attention a lot more closely to bone density in people who are taking steroids as part of it. Now, these T-scores then are representations of how different you are from a 30-year-old. So if you're 60 years old and your bone density gets measured and it's up here on this top line here, and this is, I'll put a little smudge mark here, and that's your bone density when you're 60, we would compare you to a 30-year-old over here and say there's really no difference in you and a 30-year-old, so your T-score would be 0. On the other hand, if your bone density is down here, you're a standard deviation below a 30-year-old, so your T-score would be -1. And that's when we start to think about osteopenia as well. And when you drop from one standard deviation to the other, you double the risk of breaking a bone. When you drop down to 2, now you have a -2, you have a 4-fold risk, and you get down to a T-score -3, you're 8 times more likely to break a bone. So in fact, you're considered at such high risk to break a bone by the time you're -2.5 on your T-score, you're considered to have osteoporosis. Osteopenia, on the other hand, is between -1 and -2.5. They also, this committee of the World Health Organization that included Tom Kelly, designated what part of your skeleton we should use to take these measurements. And there are 4 of them. The lower part of your spine that I showed you, the top of your leg called the total hip, and the femoral neck that I showed you. And I also mentioned your forearm, the 33% radius. And the rule is whichever one is the lowest is who you are. We don't say you have osteopenia in your spine and osteoporosis in your hip. You get one diagnosis from all that. If you have osteopenia, there's a little formula to calculate what your risk of breaking a bone is, because if it is high enough, then you should get treated like you have osteoporosis. It's called FRAX, and it takes into account your age, height, weight, bone density, medical conditions, medications, family history, and it generates these 2 numbers of risk of a major osteoporotic fracture and the risk of a hip fracture. And if either of those are high enough, then you get treated like you have osteoporosis, even though you only have osteopenia. Once you get one of these diagnoses, then we think about how are we going to keep you from breaking a bone, whether you have osteoporosis or osteopenia. And in general, we start out with the most basic and common concept is don't fall down. That's rule number 1 in osteoporosis. And people who exercise tend to have better balance. They fall less often, and the actual activity of exercising tends to stimulate your bones to be stronger. And people who do exercise and develop muscle have an extra cushion. Muscle's a great shock absorber if you do fall. The second thing, of course, is nutrition. We want to make sure that your bones have adequate vitamin D, and that's a blood test. We like it to be somewhere between 36 and say 60. And we like to know that you're getting enough calcium. And we'll talk a little bit more about this. The only valid test to tell if you're getting enough calcium is to do a 24-hour urine collection and look at the calcium that's in your urine. There are blood tests for calcium, but your body's designed to keep your blood level normal, and it does that by taking calcium out of your bones. So it's not a reliable test to tell me if you ate or drank enough foods and beverages containing calcium that day. There are other blood tests that we order to help know if you're removing and replacing your bone at a normal rate. There's some other blood tests to do to make sure that you're not having other reasons to lose bone as part of that. It's a little bit beyond the scope of today's discussion. Then we get into the role of medications, and I would urge you to think of medications and nutrition as partners. It's like building a brick wall in your backyard. You need bricks and mortar, and you need a brick mason. If you're making bone, you need vitamin D and calcium and something to help put it in the right place. And we have 2 types of medicines that we use. We have those that help you keep you from losing bone, and we have those that help you stimulate to make new bone. We don't typically take both at the same time, one or the other. Making new bone is generally what we like to start with. These medicines tend to be more expensive and a little more labor intensive. And so a lot of times the insurance companies want you to do it the opposite. They want you to start out with something to stop losing bone. In some cases, that's a reasonable thing to do. Bisphosphonates have been around for a long time. They are medicines that help slow down the bone loss. 3 of them are tablets. One of them is an IV. The tablets sometimes upset people's stomach. And so the IV is a lot more attractive, and it can be used relatively infrequently, like once a year, once every 2 years with some patients as part of it. There are people who get on estrogen blockers called Avista and Duave, and they help bone density as well. And then there's a shot you can get from the nurse every 6 months called Prolia that also is a great help in reducing bone loss and allowing you to build up on your own, and most importantly, reducing your chance of breaking a bone as part of it. All these medicines have the potential to have side effects. You need to do them in the conjunction with discussing with your doctor. In general, the risk of side effects is far lower than the benefit. But if it was so easy you didn't need to see a doctor, then you could just go to Walmart and ask the pharmacist for it. That's not how this works. So you do need to have consultations with a physician to decide this. These 2 are injections from that you can do at home. And then the last one is an injection from the nurse every month. So they all have pros and cons, but in general, they have a remarkable ability to reduce your risk of a fracture as part of that. I want to go back to these three categories. Category number one is fall prevention and weight-bearing exercise. When your bones feel the activity of walking against gravity, i.e., an astronaut has a terrible problem with osteoporosis because there's no gravity. But a 20-minute walk 5 days a week can make a difference in your bones. And so that's a good place to start. Jogging can also help your bones. Doing Tai Chi helps balance a great deal. Going up and down stairs helps. Dancing, tennis, yoga, these are all reasonable things to think about if you are able and so inclined. We want you to have good agility and strength and balance and not fall, and also stimulate your bones to get stronger. Weight bearing by itself, except in rare circumstances, is not going to fix your osteoporosis. It helps, but it's really a three-legged stool, as you saw in that chart before. It's the activity, it's the nutrition, and it's the medication that make a big difference as part of it. They all work together as part of this. And speaking of nutrition, this is some of the handout information that we give to patients. In general, your goal is to try to get about 1,000 milligrams of calcium every day. If you're a bit younger, you might need more. If you've got problems with your intestinal tract and you can't absorb calcium, if you've had surgery that removed part of your intestines, it may make it challenging as well. So you might need more. We don't think of doubling or tripling to 2,000 or 3,000 is particularly helpful. That's when your kidneys have to work extra hard to get rid of all the extra calcium. So more is not always better. If the safest place to get your calcium is in your food. If you can't get it in your food, you can take tablets. I prefer calcium citrate-based tablets because they're easy to absorb and they prevent kidney stones to some extent. Dairy is a huge source of calcium, and interestingly, it's the skim dairy products that have all the calcium. When they take the fat out, it concentrates the calcium. So skim milk has more calcium in it than whole milk. Everybody thinks whole is whole with things. Yeah, but it's whole with fat. It's not whole necessarily with calcium. Similarly, low-fat yogurt has more calcium in it than whole milk yogurt as well. And skim cheeses have more calcium than whole milk cheeses. So in general, that's a good thing to think about. If your goal's 1,000 a day, a full glass of skim milk will get you about a third of the way there. An 8-ounce serving of low-fat yogurt will add another 400 milligrams, and a bit of cheese, you'll be over the top as part of it. But it's the 24-hour urine collection, which is not a particularly fun test to do, but it's not terribly expensive, and there are no needles involved. But measuring the calcium in a 24-hour urine is the best way to know if you've got enough calcium. It's not the blood test. And speaking of sources of calcium, as I mentioned, the dairy products, cheese included, vegetables are good sources of calcium. They have about 50 to 100 milligrams per serving. This is a partial list. These are certainly not the only vegetables with calcium as part of it. And if you've got favorites, you can Google them and look them up. And then we have fruits and nuts and seeds and fish and molasses and tofu and so forth. So there are lots and lots of sources of calcium, particularly if you don't like dairy or you're allergic to dairy. And the plant-based milks like almond milk and soy milk that have calcium, you just have to learn to read labels and use Google to help guide you as part of this as well. If you're going to make changes in your diet, it takes your kidneys about 5 days to get used to it. So I wouldn't collect a 24-hour urine until your changes have been in place for about 5 days. Beyond calcium and vitamin D, are things like magnesium. I meant to mention that vitamin D is not really in food, so most people need to take a supplement, typically about 1,000 units a day. Some people more, some people less, and we measure the blood level to keep to know if you're getting enough calcium. I think I told you about that in the beginning. But magnesium is also an interesting supplement. If you're getting green vegetables in your diet, you're probably getting enough magnesium, and taking extra magnesium is not necessarily helpful. There are some people that are on some medications or have had intestinal issues and they don't get enough magnesium. You can measure your magnesium to some extent with a blood test, and it can give you a clue about whether you need more of it or not. And then vitamin K, people talk about a lot. You can buy calcium over the counter that has vitamin K in it. Again, your own intestines make vitamin K. It's not clear if you don't have a problem with your intestines and you haven't been on lots and lots of antibiotics that you need to take it. So a healthy diet typically contains it, and your intestinal bacteria will make it. I'm not sure I'd spend extra to get vitamin K and magnesium in my calcium unless your doctor told you you absolutely need to. That's part of it. protein's important for bone health and muscle health. And typically, most folks need to get between 45 to 70 grams a day. It's based on your weight, 0.8 grams per kilogram of body weight as well. And it's good to space it out during the day. There are a lot of over-the-counter supplements that claim they'll make your bones stronger, and late night TV commercials that do that as well. You've got to remember that the FDA is forbidden to regulate those supplements in this country. And so what they say on their label may not be actually what's in it. There are no requirements that they be studied for efficacy. There are no requirements that the safety be declared. And so just because it's over the counter doesn't mean that anybody has proven it's safe or effective. I tend to stay away from those. They tend to be expensive, and anybody that's touting them tends to be making money from them, and it's not necessarily in your best interest. So we'll be very careful about jumping onto the supplement bandwagon just because your local health food store told you they're good for you or good for your bones as well. We like to measure what's going on in your body, and if you actually need something, you can look at the label and see if it's been certified by the United States Pharmacopoeia, USP, or National Science Foundation, NSF, to show that it actually contains what they say it contains before I would spend money on it as well. I mentioned to you lab tests, and I'll go over a few of them here on the left. These are typical lab tests that you would get from your family doctor if you had a routine physical. A couple of exceptions are phosphorus. That's not on a typical blood test regimen, and it's an important ingredient for bone. So we do like to check it in the blood work. Vitamin D levels are checked, and we talked about the 24-hour urine. If you're a male, we sometimes check your testosterone level, the parathyroid hormone, and thyroid as part of this. Chemistry profile and CBCs are real common that people have already had those. We sometimes get into a little more specialized testing if there's reason. Make sure you don't have a gluten allergy. Make sure you're not iron deficient. Have a problem with a genetic problem with homocysteine or prolactin. Sometimes you have too much cortisol in your body that can cause problems, and you can measure that with urine or saliva. There's a condition where your allergic cells called mast cells make too much tryptase. It can cause bone problems as well. And so we do some of these tests, and we can also measure the blood tests that tell us how fast you're removing and replacing your bone. They're called bone turnover markers. And finally, vitamin B6 can be a measure of somebody who's got a genetic abnormality. If you have too much vitamin B6 in your blood, it can be an indication of that, but most of the time it's an indication that you've bought a big bottle of hair and nails or something like that, thinking it's going to help your hair, and it's got massive amounts of vitamin B6 in it. And by stopping it, you get away from the toxic doses. So lots of things to think about here, most of which should be done in conjunction with your doctor as part of that. This is a chart of the medications that the FDA has approved to treat osteoporosis. And I want you to draw your attention to the top of the page, because these are the categories that the Food and Drug Administration uses to define whether a medication has been proven to be effective. They look at drugs to see if they've been used effectively in women who've gone through menopause and trying to either prevent osteoporosis or treat it if they've already gotten it, or people who've been on steroids for a variety of reasons, regardless of menopause, and they're trying to prevent or treat osteoporosis as well. And certainly the forgotten sex, males who have osteoporosis. There's a category where the FDA's looked at the drugs to see if they're effective in males as well. And the check boxes are the ones that the FDA has found evidence that they're actually helpful. And you can see on the left, this list of medicine, there are 4 of them that end in ATE. These are called bisphosphonates. They've been around a long, long time. The Germans invented bisphosphonates in 1860. They weren't used in humans for treatment until the 1980s. But 3 of them are tablets, and 1 of them is an IV that I mentioned, and they've been used in lots of different cases: postmenopausal osteoporosis, steroid-induced osteoporosis, and even male osteoporosis as well. Rituxan is this estrogen blocker, which is effective for women. Estrogen has been noted by the FDA to help reduce the risk of osteoporosis. It's not considered a primary treatment because of potential side effects. And so if you're taking it for menopausal symptoms, that's great. There are a lot of other good medicines and better medicines if you're trying to take it just for your bones. Calcitonin is a nasal spray that's been around a long time. They took it off the market in Europe because of potential side effects. They're still available in this country. It's not particularly potent, and so we don't use it a whole lot. One of the newer drugs we have is this every 6-month injection called denosumab. It's been used in women after menopause, and women and men who have been on steroids, and males who haven't been on steroids as well. Its biggest issue is not its side effects. It's the fact that you need to stay on it pretty routinely every 6 or 7 months. If you're late with it or stop it abruptly, you can go through something called rebound bone loss with multiple vertebral fractures, and that is not a good situation. This is unique to that medicine, so it's a commitment to be on that drug. There is a way to transition off of it, but you have to do that in conjunction with your doctor. You can't just wake up one day and decide you don't want to take it anymore as part of it. And the last 3 medicines on the list are the bone building medicines. They have a unique ability to stimulate your bone building cells to recreate your bone. 2 of them are self-injections, the teriparatide and abaloparatide, and one of them's a shot from the nurse every month, romosozumab, which actually not only helps you build your skeleton, but reduces the risk of you losing it as well. So we have a lot of choices. You just have to kind of match them with the folks that need them and their individual circumstances as well. So if you find out you have osteoporosis or osteopenia, or you're even worried about it, there are 3 things that you should consider. First of all, sit down and talk to your doctor or nurse practitioner or PA and see if you're a good candidate to get a DXA bone density test as well. The other thing, of course, is to talk to your physical therapist. Make sure you have a good tailored program of activity, exercise that helps your balance and stimulates your bone and prevents you from falling. And it's something that's reasonable and realistic for you to do every week. It may be taking a 20-minute walk 3 times a week. It might be something more. There's no point in being assigned a bunch of exercises, though, that hurt or you're not going to do. It's just not worth it. But some exercise in general is helpful. And also to talk with a dietitian to see if you've maximized your calcium intake through your diet and perhaps don't have to take calcium tablets as well. And there are lots of choices, as I hoped I showed you as part of this. If you've already been diagnosed with osteoporosis, it's a great time to sit down with your doctor and talk about medication choices. It's nice to try to keep your steroid dose as low as possible. And certainly in the case of vasculitis, there are lots of medications that can help you reduce your steroid dose. It's good to remember that the diet and exercise alone, while helpful, are not going to reverse osteoporosis. Prescription medications are really where it comes. And hip fractures are a big deal. They even cause fatality. So we are really working hard when we think about osteoporosis to reduce the risk of a hip fracture. If you've got a lot of questions about osteoporosis, there are good online sources that are reliable. That first one is the National Osteoporosis Foundation. And I should remind you that May is Osteoporosis Month, and they are trying hard to make sure that people who need to know about this know about it, and people who know about access to treatment, access to good exercise, access to good diets, and access to bone density testing are all available. The International Osteoporosis Foundation is the next one. They also have reliable information on their website, and the International Society of Clinical Densitometry can help you find good places that do reliable bone density testing with data that you can rely on. The rheumatology website, American College of Rheumatology website, has very detailed guidelines about how to evaluate patients who are taking glucocorticoids and decide whether or not they need a medication, and if so, which one. So they are the leaders in the field for deciding about steroid-induced osteoporosis. I'm going to stop there and see if we've got any questions to go over. I think I've already made these statements as well, but are there any questions in the chat that I need to try to address?
There are some questions. If you would mind, you could stop sharing your screen. I have gotten a few, and we had a few that were sent in to us in anticipation of people not being able to be here. So we do have a few good questions. The first one in the question box is, how prevalent is AVN with vasculitis? This person has EGPA, and if you don't know maybe how prevalent it is, what they should look for, how to treat it, that sort of thing.
So AVN is short for avascular necrosis, and sometimes people who take steroids can get a situation in which the bone actually dies. That's very different from osteoporosis. That's a question of not getting enough blood flow to the inner workings of your bone. And when the bone is starved of its normal nutrition, it's actually going to die. It's not a piece of rock, it's a living tissue. And it depends on, as I showed you, remodeling, taking away old bone, replacing it with new bone. And if you deprive it of blood supply and nutrition, it can die. And we don't have a good way of predicting who's going to get AVN. It happens in vasculitis cases of on steroids probably more often than, say, rheumatoid arthritis as well, and probably more often than it does in patients with asthma who take steroids. And so we're aware of it, and it's a good thing to check on. It's typically manifest by having pain in a limb, the leg or the arm, or sometimes the shoulders. And X-rays and MRI scans can help diagnosis, but I don't have a percentage that can tell you. So it's one of the rare side effects, and sometimes the osteoporosis medications can help it as well, but sometimes surgery is involved.
Understood. Thank you so much. I appreciate understanding what that is, first of all. And the next question that's in, just by, as to mention for the people that are watching today, if you have a question, if you type it in the Q&A box, we will be happy to ask that of Dr. Tanner. The next question that I saw is about risk associated with inhaled steroids, like how much is it absorbed?
Very little of inhaled steroids is absorbed. About 40 years ago, as inhaled steroids were coming onto the market, one of the big hallmarks was we'd only treated things like asthma and COPD with oral steroids, and clearly they had side effects. And inhaled steroids were a big breakthrough because just tiny fractions of percent of it actually gets absorbed. But some work done by a man named Elliot Israel and others in the 1990s and 2000 did show that, yeah, you can, some people are particularly sensitive to them and you can get bone loss, but it's incredibly uncommon. And if you're at all worried about it, you can use bone density testing to kind of see where you are with it.
Okay, thank you. And interesting question from one of our viewers is, she says, I just fractured my pelvis last weekend. She says she's 57 and active and hoping that she can recover well, even though she was on prednisone for 10 months. Do you have any specific suggestions for her?
Well, I can't really treat you in a webinar like this. I'm not your doctor, and I don't know all your specifics. I will tell you that pelvic fractures are sometimes considered part of the range of osteoporotic fractures, and getting a bone density test and meeting with a physician who's knowledgeable in the world of osteoporosis and goes through the things that we just talked about in terms of diet, exercise, blood work, and if medications are appropriate, helping select one based on that information.
Thank you for saying that. I was just going to say I'm an MPA patient and broke my ankle during COVID, and after surgical repair and everything, I did get a DXA test, and it helped me know what to do moving forward with my life after I had recovered from the ankle fracture. Okay, so the next question is, has the research shown that Prolia significantly produces bone density? What are the side effects of Prolia? I have been on steroids for a couple of years, starting with 60 milligrams for a couple of weeks and then tapered down to 1 milligram a day.
So denosumab is that injection that I mentioned that you get every 6 months, and it's remarkably good at reducing your risk of fracture. The FDA had the company do a study of having people take it for 10 straight years, and we learned a lot from that study. One is their bone density continued to improve, and their risk of a fracture continued to go down. And so we're very happy with it. I think the biggest side effect we worry about is what I just told you about, and that is that you can't stop it suddenly because you can go through rebound bone loss. So it's very important that at some point, if you decide it, or your doctor decides you need to get off of it, you go through a transition period, and that's a complicated set of events with substituting medications and monitoring your bone turnover markers. It's not something you should try to do on your own without careful monitoring. But
Okay.
it's a very effective drug in steroid-induced osteoporosis.
Okay, thank you. And then I had one question that I thought of during the webinar. I learned so much today, but one question was, how often should you have the DXA test? I mean, I had one in 2011 and 2021. How often should I have it after that?
Well, the answer is a two-part answer for anybody getting a bone density test. One, of course, is does your doctor think you should have one? But what happens to intervene mostly is what your insurance will allow you to get. And
Mhm.
most insurance companies don't allow them more than once a year. Medicare has a blanket statement that I showed you in the slide that says you can get them every 23 months unless you're on steroids, and then you can get them more often. So it tends to be every year or two. Now, if you have a whole series of normal bone density tests, I don't think it would be productive to keep getting them every year. But if you've got something that you're monitoring because of steroids and you need to make sure that things are not turning in the wrong directions, and then every year for a while to keep an eye on things, or you made a big change, you've gotten a medication that you've started, you want to know if it's effective or not. That's the time to do them pretty regularly. But we typically think of bone density testing in the range of every 1 to 2 years.
Okay. And speaking of medication changes, this is a very common question for a vasculitis patient. Does rituximab or immunosuppressants affect our bone loss?
A lot of times when rituximab is given, it's given in conjunction with a bolus of steroids to keep you from having the side effects during that day. And that might have a little bit, but that's a lot different than taking steroids every day. And so immunosuppressive drugs may have some role. Some of them do, some of them don't in your bone health, but the benefit that you get for treating the vasculitis, for example, is far more significant than a risk of the problem with your bones. And again, you can have it monitored with your bone density test.
Right. And I was just thinking, we talk a lot about bone density issues as we age, as you showed us today, and the increased risk. But what do you do to lessen the risk and monitor for bone loss if you're younger?
Well,
Because and you're on vasculitis, and you might be on a low dose of steroids for the rest of your life or something because of flares.
Well, if you're a young woman or even a young man and you're a teenager and you're still growing bones, it's really important that you get the adequate calcium and vitamin D and you're active so that you stimulate your bones to fulfill their genetic potential. Around age 25 or 30, when you hit your peak bone mass, you want to be able to look back and said, I ate right, I exercised, I did the best I can, even though I was on steroids or whatever, and achieved it. There's an extra way of monitoring some of the natural improvements to bone density or assistance in keeping good bone density with women, and that's menstrual cycles. If menstrual cycles are regular and are happen without necessarily taking anything, that's great. If they're not regular and there's problem with it, and you're not being suppressed for medical reasons, then you need to be careful because essentially you might create an early menopause. And if you're in early menopause, then you start to look at bone density very differently. You start to look at T-scores and so forth. So somebody who's got a lifetime ahead of them, exercise, good nutrition, and it's female, having regular menstrual cycles are important avenues to good bone health.
Okay, thanks. I just wanted to ask on behalf of the younger viewers today. And there's a couple of questions about exercise in particular. One of them is a 34-year-old who's been tapering on her prednisone, but she just wants to know what's the impact of steroids on bone density. Is it safe for her to do workout while on the prednisone? I guess that's her main question.
I don't know about your particular circumstance and the whole of your condition, and so I can't really comment on you personally. But in general, I mentioned working with a physical therapist who's trained and knowledgeable about people's medical conditions and can assess you at the beginning and get an exercise program with somebody who's a professional and can help guide you through what's appropriate given all your circumstances. Certainly weight bearing exercise is important, but also fall prevention. And if you've got balance issues, it may be part of your treatment plan to improve your balance as part of the overall guidance from a physical therapist. So that's why we rely on professionals like physical therapists to assess you and make some direction. But typically most people can achieve some level of exercise. They just need to be careful.
I love the advice of having a physical therapist advise us on what exactly we should do. And is it easy for a vasculitis patient to get a referral to a physical therapist?
It's very easy. I mean, certain states they don't even require a doctor's referral, or if they are, or the physical therapist will see you and then send the note to the doctor and say, "Will you please sign off on this?" after they make an assessment. So, yeah, and I think finding physical therapists that are knowledgeable in your area, it's not too difficult. But they're the folks that are hands-on, ready to assess your skills and what you're able to do and can't do, and what's a good treatment plan going forward. So yeah, I would encourage you to try to get hooked up with one. Yeah.
Well, thank you so much, Dr. Tanner. That is it for our questions today, which means basically your presentation answered most of them.
Good.
Because sometimes we run long with questions, and you did such a great job. I learned so much today. I did want to say thank you so much to you, and just I'm going to share my screen here for just a second if I can make this work. Just to say thank you to Dr. Tanner for sharing his time with us today, and to the Vasculitis Foundation for supporting these medical webinars that aid our patients and young doctors. And thank you to all of you that were watching today. And just as a reminder, we will have this published soon up on the Vasculitis Foundation's YouTube channel, and everyone who registered today will also get a link. And there's so many compliments to you in the chat area. I don't know if you see that, Dr. Tanner, but I did want you to know that everybody's saying thank you so much.
Well, you're quite welcome, and thank you for inviting me. And I'm glad you found it helpful. And I wish you all better bones in your future.
Thank you. We want better bones. Thank you so much.
All right. Bye-bye.
Bye.